Hello, good afternoon, good evening, everybody, to our next session of autism in early childhood diagnosis, characteristics, and treatment. It's a great pleasure to introduce you the moderators of this session that worked very hard to arrange it. Thank you so much, Lydia and Judah. Dr. Judah Kohler is assistant professor in the Simon Fox School of Education at the Hebrew University, where he directs the Autism Child and Family Lab. Professor Lydia Gabis, currently Director of Technology and Digital Health Division of Clalit Hospitals Healthcare, autism researcher at Tel Aviv University and Siegel Brain Center, established and directed the Keshet Center at Sheba Hospital until 1 month ago. Professor Gabis will start with her first talk. How early is early diagnosis? Professor Gabis, the screen is yours.
Okay, thank you very much. Thank you for the introduction. I'm very honored to be here, and it's quite difficult to give a talk after Professor Klein, which was so comprehensive. So please bear with me when I'll discuss the clinical features of early diagnosis and how early can we go. So the main questions that we deal with are what are the early signs and the validity of the early signs and symptoms, what's the early phenotype and the milestones, and when do we start to see the early discrepancies. What's a different incidence, and I'll emphasize the incidence in prematurity, and I allude a bit to the causation. So let's start first with the current status of care. What's really the age of diagnosis? And when do the parents really start to worry? So from parents' reports, we can see that in about 50%, they report having some concerns before age of 1 year. And most of the parents reports having concerns between 1 and 2 years. The most common presenting concern is usually delayed language, but there are also other concerns that we can recognize as signs of ASD, like inconsistent use of eye contact, of social smile, lack of imitation, no response to name, no interest in others, lack of emotional expression, no direct vocalization or joint attention, and no requesting behaviors or requesting gestures. So when we can look at parents, and that's a bit disconcerting to see that in a guide to parents, it's written that as a parent, of course, you don't want to believe that your child has a problem, but you have to be very assertive. You have to monitor your child's development, to take action, and to trust your instinct. And about us, it's written that ideally your child's doctor will take your concerns seriously and perform a thorough evaluation for autism or other developmental delays. And of course, there is some emphasis on regression. From reports that we saw at our center, we saw many concerns that occurred very early on. Some concerns that appeared even at birth, of low muscle tone, of delayed visual maturation and no eye contact, even children that were thought to be blind because they were not looking. At ages of 3-4 months, feeding difficulties, irritability, not bringing the hand to the mouth, all those are reports of the parents, prolonged looking and playing with the fingers, interest in objects more than people, the child being too quiet, no vocalization, signs of some motor delays, children that were reported that were starting crawling, but they were crawling only in circles. They were very interested in remotes, in magnets, sometimes started language in a different language, a Hebrew-speaking child. His first words were in English. And nevertheless, even though the parents report those signs very early on, the age of initial referral is in 1 or 2 cases at 6 months, but usually much later. And of course, the final diagnosis usually it's about 6 to 1 year later. And when we look at statistics about the reality of early diagnosis, Professor Klein also discussed it that the average age at which diagnosis is usually made is usually between 33 and 50 months, that despite having all those wonderful tools of early diagnosis. And in a study that we made on a very defined population of children with Fragile X syndrome, we measured the time from the initial concerns to the diagnosis of autism and later on to the diagnosis or the genetic diagnosis of Fragile X. And we found a huge difference of many years. And of course, since this syndrome is more suspected in boys, this delay was much more longer, more prolonged in girls. But we see publications. One of them was very seminal in 2020 by Dr. Pierce. The diagnosis that is made at 14 to 16 months may be stable, and when we look at follow-up, most of those kids will be proven with ASD. So how can we prevent and how can we diagnose and treat earlier? This concept of very early diagnosis and what was called infantile autism, it's quite old. Leo Kanner wrote about it in the 50s, that there is a syndrome that starts early, and he describes some of the signs. When we look at typical patterns of development, we can see that the changes very early on are very fast. And there are different patterns, kids that don't acquire any milestones, kids that may have regression of milestones, and most of the kids, they have different patterns of delays, and some of them may, over the time, get closer to the typical curve. But what I would like to point to is to this early period in life when we start to see those very early discrepancies between those trajectories. And when we look at the perinatal development, in the normal or typical development, we can assess that there is some flexor tone, eye contact that starts from birth, mimicking of expression also starting very, very early on, some synchronized general movements, and I'll show you a movie about general movements, some degree of head control that starts very early on, symmetry that occurs all the first 2 years of life until some dominance starts to appear. There is, that's the opposite, some more interest in faces than in objects. Focus vision, that it's very, very close. It's made like that to see best the parent, that it's about 20 centimeters away. And the focus of the vision is for the caregiver and for the face. And there is some gradual increased motor control and social engagement. And we can start to see in all those milestones sometimes minor delays. We can see children that the tone of birth, it's hypotonic, it's low, some delay in eye contact and in social smile. The general movements are unsynchronized. There may be some head-leg asymmetry and more interest in objects than interest in faces. But in all those early signs, we have to think and discuss the differential diagnosis, because for each one of those signs, there may be many other reasons. Obviously, a baby that is not having eye contact or does not smile in response, he may have the entity of delayed visual maturation or even visual problems. A child that does not respond to the name or to the sound of familiar voice, doesn't make noises to get your attention, may have hearing impairment. A child that does not point or wave or make any gestures or follow gestures, doesn't imitate movements, may have some motor problems. Children that don't reach out to be picked up, don't like to be touched or cuddled, may have sensory issues. And of course, language delay, it's a very big differential diagnosis. And for all those signs, we have to think that we may also see some global developmental delay, either as a comorbidity, but sometimes as a differential diagnosis to ASD signs. Just to show you what I mean about the general movements, that's a movie of a term baby of 2 months, in the way that the baby is moving. And that's a baby that was born premature, and he's 2 months at the corrected age. And his movements are lacking in the repertoire, are not synchronized, and they are missing those very small movements that you can see in the typical child. Looking at those very early signs, we try to see whether we can recognize autism very early in premature babies that we actually follow from birth or from their release from the prematurity unit. And I will start with a specific story of one child that was born at 26 weeks. He was 500 grams, which is considered also IUGR. It was a low birth weight even for 26 weeks. He spent a very long time in the NICU. He was very, very sick. And the parents were told very many times that he will either not survive, but if he will survive, the prognosis is of severe cerebral palsy and intellectual disability. They were never told that they may be a different diagnosis. At 2 years follow-up, he actually did not show any signs of CP. He had normal motor and fine motor development, but he showed some delays in language and communication. And later on, his language skills actually were quite high for his age, but he has a lot of echolalia, minimal nonverbal communication, no gestures at all. His growth was also very stunted as a complication of prematurity. And he was diagnosed with autism spectrum disorder, actually with a high intellectual disability, with a high intelligence and without intellectual disability and without cerebral palsy. When we looked at all the cohort of 871 children that we identified and followed from very early on, we saw that the diagnosis of global developmental delay and cerebral palsy was like we see in the literature from this cohort of premature babies. However, our cohort showed about 10.3% of autism spectrum diagnosis. And we try to differentiate the diagnosis and to look at each specific week that the child was born, from 24 weeks to near term, and to try to identify whether we see a differential trajectory between boys and girls. So when we looked at the birth week, we saw that there is a linear correlation between being born earlier and the likelihood of autism. After, however, 32 weeks, this linear correlation stopped, and the incidence remained between 3 to 5%. It didn't decrease, so even in near term, there was a higher likelihood of ASD. And we did identify that the trajectories between boys and girls were different. When girls show that they're impacted more by the degree of prematurity than the boys. And the boys had elevated risk of ASD related to prematurity that goes on even at near term. For girls that were born later, were still premature, but were born after 34 weeks, the risk became very low, like the general population. So our message is that we need to be aware of ASD signs and symptoms in premature babies at all levels of prematurity, and to pay additional attention to examining girls. And this link of autism and prematurity was investigated during the last few years. And we all know that when we have a brain architecture and plasticity that is typical, the neural circuits are built in a specific sequence. If this sequence is harmed in some way, still there is a very large window of opportunity for skills development. The plasticity happens for quite a few years. However, this adaptation in the face of impaired brain circuits may be more difficult and more costly for the brain than getting it right in the first time. And the result of abnormal connectivity may be linked to autism. We look at babies that were not born premature and try to see what can be some additional early signs and what can be the hints or the red flags between 0 and 1 year. So we can see some differences in the BERA or ABR latencies that may be prolonged and detected soon after birth. We can see early deficits in empathic abilities. And yes, there are quite a few studies that even 6-month-old babies can show empathy. So if you look at children at risk for ASD, like siblings, you may see some deficits in their empathic responses. And other hints that we looked at were motor issues, especially hypotonia, which we found it as an early sign for autism in infancy. And in general, motor delays are an early sign and are more common in girls that eventually will evolve to ASD than in boys. There are additional red flags that are provided to us by general health red flags and some environmental red flags. I mentioned before the parental concerns. As a guide to parents said, we need to listen to the parents and to listen to their concerns. We can see a high prevalence of sleep and feeding difficulties very early on. We can see developmental differences in twins and siblings. Different reaction of the peers, like looking not at the child at risk for ASD, but looking what are the responses of the other children at the same age to the child at risk for ASD. And another issue that also Professor Klein alluded to it, we can look at the parents in the way that they speak to the children, and we examine the child-directed speech of the parents, and we found that very early on, parents are responding differently in the way that they talk to children with ASD than to typical children. And of course, this is an issue that can be addressed by intervention. There are some hints that we start to identify that are prenatal by neuroimaging, by genetics, and by fetal behavior. And just to start with a nice movie that shows how beautifully we can see the fetus by fetal MRI. Of course, we're not doing fetal MRI for no reason, but just to demonstrate that the fetus or the baby that was not born yet is moving, of course, in the uterus and has prenatal behavior that can be measured. We can look at facial and mouth movements and at hand to face movements. And the same movements we can see not only by MRI, which is quite fancy just for the presentation, but we can see the same signs and symptoms by using ultrasound. We used morphometric measure, and Professor Simon Baron-Cohen talked yesterday about this study, looking at the measurement of anogenital distance as a marker for hormonal exposure prenatally. This is a marker of exposure to prenatal sex steroids. We know that males produce twice as much fetal sex steroids that produce the masculinization of the brain and exert epigenetic influences. This study is still going on, but we start already to see some findings, especially proving that this anogenital distance, the AGD, is a good measure and representative of prenatal sex influences. Other prenatal morphometric hints are very obvious, and all of us know about them. There are some overt brain abnormalities that we can see by ultrasound, malformations that hint to specific syndromes like absent corpus callosum, Dandy Walker, gyration differences, tuberous sclerosis. All those we know that are prenatal risk factors and disorders that are highly associated with autism. And also we can see brain abnormalities that are caused or are acquired either by insult or by viruses. We know about CMV damage to the brain and the outcome of ASD, the Zika virus. And I didn't even want to write it, but I hope not that we'll not have to write coronavirus here. I don't know if you recognize this person. He deceased. His name is Kim Peek. He's the character behind the real character behind the movie Rain Man. And Kim Peek, as you can see by his dysmorphic features, he had absent corpus callosum and, of course, autism, as you could see in the movie. Other hints that we found was that borderline ventriculomegaly, that it's not a very large ventricle, but it's borderline. There is some increased risk especially for ADHD, but also some increased risk for ASD. Brain growth trajectories that are different. There is a very nice publication from the group at Ben Gurion about fetal head growth and autism spectrum disorder. So we can look at brain growth trajectories with ultrasound. And also in our studies and other studies, we can find some cerebellar difficulties, some cerebellar changes and growth changes that also may be a morphometric hint for future ASD. In other talks, we were reminded about genetics and the genetic link to autism. But the obvious genetic link that it's very, very easy to search for is Fragile X premutation and full mutation. There is a national screening in Israel that it's not common in other countries, and it's very important to look for genetic risk of autism. There are other syndromes that may show signs in utero, like in tuberous sclerosis, we can see growth in the heart, which is called rhabdomyoma, that may show as a risk for tuberous sclerosis, and then we can check genetics. In other genetic disorders that are quite common and linked to autism, like P10 and neurofibromatosis, we can see microcephaly in the fetus. We can do microarrays during pregnancies. It's quite routine, and there are some deletions and duplications that may be linked to autism. And in quite a few cases, there is also whole exome sequencing performed in the amniotic fluid. And as we heard, that there are more than 110 identified genes that are highly linked to autism. Some of them are listed here. If the whole exome sequencing during pregnancy will show one of those genes, we can think of a child that is at high risk from prenatal diagnosis. But I cannot finish talk discussing early signs and early markers during the first year of life and even before without emphasizing what we're doing about it, about emphasizing the early intervention. We have a wonderful follow-up here in Israel of following infants at Tipot Chalav. We can recognize early gaps in development. And of course, as I mentioned, gaps in the development of preemies that have a different trajectory of development. And we have to pay attention of what it means, the corrected age in preemies. And we have a pretty good network of early intervention that can address all those areas of development. And the aim of all of this early intervention is for better function and participation of the child. However, we can think that early red flags may also be masked by comorbidity, and we need to think about differential diagnosis. Many times we recognize early signs because the gaps are very major. And if the gap is very big, then it will hint that we're dealing with higher severity of ASD. We really need to emphasize early intervention, but the changes may not be as big as we expect. Larger gaps may show slower progress, and we need to bear in mind what also Professor Klein said, that we're not fixing a problem, but we're finding an alternative path for better function and participation. So we want to advance the starting point towards a better outcome by looking at autism risk and ASD diagnosis earlier to get to a better outcome. And that's the end of my talk with alluding again to the introduction yesterday, that we need to work together, to collaborate, and if we dream together, as John Lennon said, we might make this a reality. Thank you very much.
Thank you so much, Lydia, for that wonderful, wonderful talk. Ami is a tough act to follow, but you did an admirable job.